Teresa has a question. I have Lofgren's syndrome, and although acute, I suffer from inflammation. Do you have any advice?
Oh, definitely. So, of course, I think that we're referring to is the arthritis. You know what I mean? The erythema nodosum is a little painful. And for most times, of course, you want to treat the underlying cause. If it's from a fungus, use some antifungals. If it's from tuberculosis, treat the TB. From sarcoid, I usually do what's called non-steroidal anti-inflammatory medications. That's your ibuprofen. And anytime you use these ibuprofens and Advils and naproxens, there's two organs you always got to be careful of. And the two organs is the stomach, because you worry about developing ulcers. That's why a lot of these non-steroidal medications gives you what they call peptic ulcer disease. And you worry about the kidney. So those are the two things I worry about. There's always going to be the recommended dose that you shouldn't exceed. But most of the time for erythema nodosum, those skin lesions will kind of respond to that. Now, I think you guys are referring about the arthritis. So inflammatory arthritis can be really, really painful. And the inflammatory arthritis in sarcoid can almost mimic rheumatoid arthritis, and we use, as you can tell, when we talk about drugs, many of the drugs that we use for rheumatoid arthritis kind of carry over and we borrow them for our sarcoid patients. So I think it's very important that if you have specific joints that are going to be involved, you need to tell your physician. Questions that they'll love to ask is morning stiffness. So when we have inflammatory joint disease, the doctors will always ask, in the morning, it's all right to have stiff fingers and joints for maybe 10, 15 minutes. But if you start having morning stiffness for like an hour, 2 hours, that's not normal. They'll do a physical exam. They'll look for what they call synovitis, which is inflammation of the joint. Is it boggy? Is it tender? Is it red? Is there possibly fluid in the joint that they have to aspirate? So if that happens for a Lofgren's, well, they may consider using steroids. And if it doesn't respond to steroids, then we may have to start using what we call these DMARDs, and many of the DMARDs that we talk about, especially the non-biological DMARDs, a methotrexate, a leflutamide, an Imuran, a Cellcept, a hydroxychloroquine, they don't work overnight. Most of these, medications take 6 to 8 weeks just to kick in. And in those cases, that's why steroids work quick. Or someone mentioned earlier, Humira, these TNF inhibitors, they work relatively quick too. So it really depends on how painful the lesions are, risk factors, drug interactions. So all these things factor in when trying to treat symptoms.